This is chapter 28, the child with cerebral dysfunction, and we're continuing in meningitis. There's a couple of signs that you can do looking for meningitis. One is Koenig's sign, and this is where if you lift up the leg and then try and straighten the knee, it'll cause a lot of pain. And the other one is Brzezinski's sign, and this is if you lift the head forward, so kind of bringing the chin down to the neck, the child will automatically bring their knees up, rounding their back. Now, how do we treat meningitis? Well, we are going to put them into respiratory isolation until they've been on an appropriate antibiotic for 24 hours, respiratory or droplet, whatever your hospital calls it. At that point, the germ has been weakened to the point that it can't be transmitted person to person. Does not mean the child's over it, though. It's a 10-day course of IV antibiotics typically. And our priority is to get those antibiotics started. That is the only thing that's going to get this child on the road to improving. Remember, we've got to do any cultures before we start antibiotics, or we're going to get a false negative, and then we don't know what germ we're dealing with. So get those cultures immediately, and then start IV antibiotics as soon as possible after that. Hydration, we're going to need to make sure the child's hydrated, and that's going to, what we use and how we do that's going to depend on how they presented coming in. Reduction of increased intracranial pressure. They have terrible headaches. They're usually very sensitive to light and noise, so we want to minimize lights and noise. So a calm, quiet room. Controlling seizures. Seizures happen fairly often. Temperature, almost all of these kids come in very febrile, so treating both of those, and good neuro assessments. Now, how do we prevent meningitis? Well, we do have vaccines. The meningococcal vaccine is not one that we routinely give to kids, but if there's been somebody in the family who developed the Neisseria meningococcal meningitis, we'll give them, or close contacts who have been around that child. The H flu type B, this is our Hib, which we give during that first year of life. This is the most common type of meningitis during the first year of life, and we've really seen a decrease in meningitis since we started that vaccine, the Hib. Now, non-bacterial meningitis or aseptic meningitis, it doesn't have to be a bacteria. In fact, viruses are the more common cause for meningitis. The symptoms are the same but less severe, but if you ask somebody who's had viral meningitis, they will tell you the symptoms were incredibly severe. But like most viruses, they run their course and the symptoms subside on their own. What we're doing is just treating the symptoms, so symptomatic treatment until it resolves on its own. We're still going to do that lumbar puncture, that LP, to determine if we're dealing with a bacteria or not. What we'll see is when we look at what type of white cells, we're going to see an increase in the lymphocytes, which are monocytes, because those are better at killing virus as opposed to bacteria. We also don't see the big drop in glucose. Remember with the other one we said we'd have high protein and low glucose, so we won't get that low glucose with virus either. Now, encephalitis, this is just so sad when we see these. 50% of the time we don't know what causes it. It can be from a mosquito or a tick bite, so it's vector-borne. You get bit by an infected mosquito and you contract it. It can be post-infectious involvement of the CNS. So after you've had some sort of an infection, such as herpes, it then travels to the CNS and you get encephalitis. Onset, it can happen suddenly or it can be very gradual. Usually it starts out non-specific and then kind of increases in severity and specificity. So you'll start with malaise and fever, developing into a headache, developing into stiffness, turning into tremors and seizures, leading to coma, and finally death. Our treatment is mostly supportive. If it is herpes, we can use acyclovir, but we really don't have good medications to treat this. We're just treating symptoms. One type of encephalopathy is HIV. We talked about this earlier. One of the possible complications of HIV is encephalopathy, but in kids who have HIV, we see this far more often than adults. In fact, 30 to 50% of the time we'll see encephalopathy. And this is an unexplained neurodevelopment regression. So they go from being meeting all their developmental milestones to losing those milestones they'd already met. And they end up looking like a severe CP kid, kind of stiff and rigid and non-responsive. They'll have seizures. Prognosis is very poor. Early intervention, we may be able to slow down the progression, but that's about it. Okay, rabies. Rabies is a really interesting infection. It's a viral infection of the nervous system. The problem is once you have symptoms, it's almost always fatal. There's an international rabies team that will come and take over the child's care. This will be in the ICU, and they'll monitor it, and even with that, they rarely can save anyone. It's almost always fatal. It's transmitted by saliva from an infected mammal. Usually that's a wild animal, but could be a person once we have somebody who's infected with it. So our best treatment is prevention, telling kids to stay away from wild animals. The incubation most often is 1 to 3 months, but can be anywhere from 10 days to 8 months. So the child gets bit by something, they don't get sick, they think it's fine, they don't say anything, and once they've developed symptoms, it's too late. Raccoons and bats are the other one that are kind of notorious for carrying them. So you get bit, which you get the saliva, then you end up with inflammation in the brain. The symptoms we're going to see: malaise, sore throat, convulsions, choking. They don't want to swallow because of that sore throat, so you see all the drooling and foaming at the mouth. Fever, excitement to external stimuli, so any sort of sound or movement or lights they react to, and can be kind of bizarre reactions possibly. And maniacal behavior, so very bizarre behavior. You get spasms of the respiratory muscles, which cause apnea. We can treat this with passive or active immunity with the human rabies immunoglobulin or hyperimmune anti-rabies serum, or active immunity with human diploid cell rabies vaccine. And that's given at 1, 3, 7, 14, 28, and 90 days after they've been bit. Remember, once they have symptoms, it's too late. We really can't treat them. If somebody has been bit by an animal, we contact the local health department. If they can catch that animal, the health department will test the animal to find out if it had rabies or not, so the child doesn't have to go through the immunizations. And if they didn't catch the animal, there's certain animals that are more prone to carry rabies and others that aren't, but they usually will do the vaccines just because if that animal did have rabies and we don't treat them, they're going to die. Rye syndrome, this is another very sad syndrome. This is toxic encephalopathy and characterized by fever, profoundly impaired consciousness, and a disordered hepatic function. So what we'll see is the liver will be enlarged with fatty infiltration. We see severe brain edema and decrease of the enzymes that convert ammonia to urea. About a 40% mortality rate with this. So we diagnose it by looking for those things I just told you are the problems. We're going to do a biopsy of the liver and see those fatty infiltrates, and then on labs we're going to look at liver function, which is our AST, ALT The old names for those were SGOT, SGPT, and LDH. We're looking for elevated ammonia levels because they can't convert ammonia to urea. We're also looking for decreased clotting factors and decreased blood sugar. So the cerebral edema is what is the greatest threat to life, so we're going to do what we can to treat that, but mostly we're doing supportive care. They'll have low blood sugar, so we're going to give them, treat that. We're probably going to give mannitol and steroids to try and control or reduce the cerebral edema. Eliminate factors that might raise the intracranial pressure, so that calm, quiet room, dim lights, not suction unless we need to. These kids, we're going to sedate them, and we're probably going to use those paralyzing agents that we have, like Norcuron, Pavulon. The big thing is prevention, because there's not much we can do once they have this, but prevention. Kids should not be given aspirin, acetylsalicylic acid, ASA, or any salicylates. That's what aspirin breaks down into. So if it says salicylic acid or salicylates on the label, such as Pepto-Bismol, children should not get that with a viral illness. Now remember, with Kawasaki's, aspirin is our main treatment, so there are a few exceptions where the benefits outweigh the risks, but in general, no aspirin to kids. Okay, seizure disorders. This is going to be too long, so I'll stop.